Hello, everybody, and thank you for joining on this webinar today. My name is Nicole Douglas, and I'm so excited to be here with you to share a new validated app offering IMO Core cSmart. A few logistics things. The webinar is being recorded and will be made available for future viewing. All of our attendees are in listen-only mode right now, but please use the question section in your GoToWebinar console and then add in your comments or questions, and we'll make sure to address them at the end. So in this webinar today, Dr. Deepak Pillai and David Arco will show you a new in-workflow approach to documentation and problem list management within Cerner Millennium. If you're joining us today, chances are you probably know a little something about who we are, and we are proud to provide the clinical terminology foundation that the majority of Cerner clients use to power their diagnosis search, but also making sure that search is connected to the right regulatory codes behind the scenes. Our expert staff manages millions of terms each year and updates them behind the scenes to make sure that you have the most up-to-date terminology and mappings to support rich clinical documentation and also make sure that your billing workflows are seamless. While you may know us as a clinical terminology vendor, what you may not know is that IMO is so much more than that. We like to think of ourselves as a healthcare data enablement company, and after being in the space for almost 3 decades, we know that data quality starts at the point of care. Our industry-leading point of care workflow solutions help clinicians easily capture coding at the point of care and also make problem lists more meaningful. This expertise extends into data quality solutions that are going to help structure and normalize that data for well-informed insights. Our footprint spans from hospitals, health systems, and physician groups to global EHR providers, health information exchanges, and healthcare analytics vendors. Before we get started, I wanted to just pop up a quick poll question. So we're curious, how well have you and your organizations implemented Smart on Fire solutions? All right, we got a pretty good mix between well and not at all. All right, thank you. And with that, I'm going to pass it over to my friend David Arco, our product manager for our IMO Core cSmart app, to talk to you a little bit more about the product.
Thanks, Nicole. As we've spoken with our clients over the last few years about the challenges in their problem and diagnosis space, we consistently hear 3 main themes. The first is their ICD-10 coding at the point of care is insufficiently specific or complete, and that leads to low Medicare Advantage risk scores, denied claims, and other rev cycle inefficiencies. Limited native functionality makes problem lists cumbersome. As a result, they're often ignored or neglected, which leads to an accumulation of out-of-date or redundant data, which further degrades its value as a clinical tool. And then here's the real upshot. These patient data, the diagnoses, and the problem list, those are the lifeblood of your EHR. They drive your reimbursement, your decision support, your quality reporting, your population health, your operational efficiency. And if this underlying data is inaccurate, you're going to have a hard time really realizing the promise of your EHR investment. So we'll pop up another poll question here to see which of these challenges you're experiencing at your organization.
Letting the votes come in, it looks like we are tied between improving problem list usability and reducing denied or partially reimbursed claims.
All right, great. Thank you all for sharing. It's great to hear from our customers and what they're up against. So what's our goal here with IMO Core? It's really simple. We want to simplify documentation, i.e. the ICD-10 coding at the point of care. And we want to make problem lists more meaningful to support the best possible patient care. So what is cSmart? Well, cSmart is our answer to these challenges that we mentioned earlier. It is a Smart on Fire app that has been built in collaboration with and validated by Cerner's code program. And it offers providers powerful tools at the point of care for better ICD-10 coding and more meaningful problem lists, which results in improved rev cycle efficiency, more accurate patient data, and an improved physician experience. So how do we go about doing that? Well, the first step to creating quality patient data is documenting problems and diagnoses meaningfully. IMO's precise problem terminology, which you may know as problem IT, allows you to document with specificity required for appropriate reimbursement and the rich clinical detail that you need for quality problem lists. The next step is making the problem list more accessible. We do so by organizing the problem list into intuitive clinical categories that facilitate efficient review and recall and identifies unnecessary problems for streamlined removal. And beyond making the problem list meaningful and accessible, cSmart also makes the problem list useful by alerting the provider to unaddressed HCCs that may impact that patient's RAF score. And crucially, cSmart does all of this while shouldering the maintenance burden for your clinical and technical resources, providing silent updates to ensure the app stays up to date across regulatory releases from SNOMED and ICD. But we really prefer to show rather than tell, so I'm going to hand the mic to Dr. Deepak Pillai, and he's going to provide a demo of the cSmart solution. Deepak, you're on mute, I think.
Thank you. Hi, folks. Thank you again for your time. As David mentioned, I am excited to share with you a quick demo of the app of our cSmart solution. Are you all able to see my screen now?
Yep.
Great, great. And as David mentioned, and based on your own feedback to that poll question earlier, as I go through the demonstration, I'll keep it high level, and if you want to have a follow-up conversation, we're more than happy to do that, and we can go deeper as well. But based on your feedback to some of the poll questions, I'll make sure I touch on some of those important things that you all are challenged with today around improving your claims, denied claims rates, problem list usability, and simplifying your workflow. What you're looking at, folks, is our app here embedded in a Millennium instance. And right out of the gate, one of the important things I want you to be aware of is that this is, as I believe David mentioned and Nicole mentioned in their talk, in what they said, this is an in-workflow solution. This is not a separate tool or widget that providers have to go to. It is part of your provider's Millennium documentation experience. In fact, as you can see in the screen, it is embedded right there in the M-Page workflow. We can also embed it as a separate link in the left navigation bar if your providers happen to not use M-Page workflow. M-Pages for documentation. For the purpose of this demo, folks, I'm going to go ahead and close out the side menu so we can zero in on the app itself. What you see out of the gate here is a longitudinal problem list that you see on the left, somewhat similar, at least in concept, to the notion of chronic problems using Cerner speak for your native problem list. But what you can notice is how each of the conditions are now organized into neat clinical categories. So that I, as a provider, when I'm seeing this patient for the first time, for example, or after 6 months, like in 2 seconds, right, I can know exactly what's going on with this patient from a cardiac perspective. I don't need to scroll through the whole problem list to look and to hunt and peck for those cardiac conditions. You can see them, like everything else here, neatly organized into clinically meaningful groupings. You may have noticed that when you hover over a condition, you can see additional details. There's notes that are added here. So we're pulling this from the comment section in the problem details area of Millennium. Another example of the application's integration, even at the database level, through information that can be passed to us through FHIR standards. A few simple icons that you see on the screen. We can call out which conditions are HCCs and which ones are not. This is somewhat similar to what's available in Millennium today, but where we're able to go take it to the next level is, for example, the color coding here, where you see certain conditions highlighted in orange or amber, which means, hey, look out, you got a document in this calendar year, versus those that are in blue, for example, that might suggest, hey, you can cool down. This has already been documented this calendar year, or perhaps some higher reimbursing conditions available. I'll highlight this in another perspective in just a moment. But it's how we can take HCC identification and build upon what's currently available in Millennium. We have this historical diagnosis tab. Folks, we've heard feedback we've implemented components of this in a variety of different EHR environments. And some of the feedback we've heard quite a while back was the fact that, whether docs are inpatient or ambulatory providers, they often document on the same conditions on repeated visits. So we can allow for that a variation here as well. By the way, I forgot to mention, there's a few other simple buttons here. With a single click, I can move conditions from a chronic to a visit and specific encounter list. Now, when I go to the historical diagnosis, what's really nice is if I activate the clinical category, we not only just show for one thing, we can show a chronological order straight up about what conditions were addressed. But we can turn on, if a provider activates our clinical categories, you can see a nice chronologic history of what conditions were addressed when. And you notice, regardless of how I said it, whether I called it primary hypertension today, or my partner called it that 9 months ago, or what have you. If it means clinically the same thing, we can organize that information and present it to the provider. And that's our core competency around the data management and the workflow around terminology and content. Folks, this next tab is particularly useful when trying to extract value out of risk-based reimbursement opportunities. As you've seen already, in fact, even on the screen, you can see some conditions are HCC, some conditions are not. We've seen that on the chronological problem list. It's elsewhere as well. Even in the search window, some conditions are HCCs and some conditions aren't. If a patient has an HCC documented on their chart, we can filter for just those conditions and put them on this list. Furthermore, we don't just dump them on this list as a long laundry list, but rather, as you can see on the screen, we organize them into meaningful categories as consistent and as dictated, candidly, to all of us by CMS and their hierarchical condition categories. Take a look at what you see towards the middle there for CMS's HCC category 85. In this test patient, we have a few conditions that fall within that category. Say I address the patient's pulmonary hypertension on today's encounter, and notice what happens to that entire category. It goes away from the highlighted orange section, and we drop it to the bottom and gray it out. And as some of you on the phone or in this webinar might recognize, the reason we would do this is because, as some of you are aware, CMS will only pay for one condition per category. So it would be erroneous for us to continue to prompt the provider and highlight for any other conditions that are in that category, because it will not result in additional risk-based premium. Now, certainly clinically, one might want to document on the CHF or what have you, and that's certainly a good clinical decision, but not necessarily in terms of additional premium, risk-based reimbursement premiums that can be achieved. Same thing with the diabetes, if you notice, by the way. If you look further up where I'm circling my mouse here, we have diabetes without complications and diabetes with complications. As you know, some of you may know, not only does CMS only reimburse for one condition per category, but they'll only do that for the highest reimbursing category in any given hierarchy. So once a provider has documented on that diabetes with complications, we move the entire hierarchy, all of the categories, all the conditions that are in all of the categories that are part of that hierarchy down. Because now we can only prompt and guide the provider down a path where additional incremental value can be achieved. I'll come back to the visit diagnosis tab in a moment. Another quick thing I want to show you is the problem list cleanup. Now, it's one thing to organize a problem list into clinical categories, which I think is wonderful as a first step, but we can go even further in our app. We can build upon that and proactively tell providers where their cleanup opportunities exist, right? So whether that's expired problems, exact duplicates, or clinically what I like are those conditions that are not exact duplicates, in fact, but are actually clinically related. Even though they're slightly different, they're clinically related and perhaps don't all need to go on the problem list at the same time. A classic example of that, in fact, is what we see here on the screen, a disease progression through various stages. Patient presents with a chronic renal disease, that sometime later they come with stage 2, sometimes later they come with stage 3. Providers don't always do a good job, as many of you may attest to, about deleting old ones and keeping new and adding the new one. They just add and add. Unfortunately, problems can lead to clutter. And this is a challenge of provider workflow across the country, across EHR environments, and so forth. The nature of digital documentation, unfortunately, is this notion of data bloat. So we can catch that, and we can proactively tell the provider. In fact, you can even see how we call out which ones are ACCs and which ones are not. We're not telling the provider what to keep and what not to keep, but we're giving them the right information so they can make an informed decision. In this case, it probably makes sense to keep the most recent or the most chronic, most severe condition. So it becomes very easy to clean up those those various renal disease terms on the problem list. Easily clean up all the examples of lower back pain. This patient has 2 CHS on their chart. We can easily clean those up. And with few simple clicks, you can see the problem list getting cleaned up here on the left as we go through those clicks. I hope that illustrates one of the pain points you all had mentioned earlier in your poll question about simplifying that workflow and problem list usability. I'd like to shift gears now and talk briefly about improving documentation and specificity to help reduce those denied claims. As you can see, we've documented on a few conditions just by moving conditions from a chronic to this visit encounter, some degree of functional parity that your providers are perhaps used to with their current experience with the native problem list. So we want to allow for some of that familiarity to continue while we build it on that with all these additional features that come with it. But if I were to add a new condition to this patient's visit diagnosis, we could easily do that. The search experience, I think your providers will find, is enhanced. So with a few simple, obvious acronyms or clinical shorthand, or shorthand in terms of searching for terms, you can easily find conditions. With a single click, you can add problem to not only today's encounter, but to the chronic problem list as well. Again, somewhat similar in that regard to what exists today, but what you get now is enhanced interaction and enhanced usability. For example, you see that hyperparathyroidism automatically added to the endocrine and metabolic section that you see on the left, in addition to this visit encounter as well. Let's take another scenario. Say I'm seeing this patient post-discharge from an acute stroke. I'm seeing them in follow-up in my office, and I want to address the patient's stroke. For those of you that are involved in billing and claims workflows, you'll notice how certain conditions, when you search for them, have a plus icon. That means that they are as specified as necessary for an billable ICD code. Other conditions, like that stroke that I'm about to document on, don't have the plus icon, meaning that ICD requires additional specificity. In fact, the only thing I can do is click on the calculator. I cannot simply add an unspecified code. By clicking on that, I'm taking down a simple decision tree that's tailored for that clinical term. I can go from stroke very quickly with a few simple clicks. I would have gone from an unspecified term that would have resulted in a .9 and a denied claim to a ischemic CVA of the right MCA distribution and a highly specified clinical term that's appropriate for ICD billing. And by the way, if I may add, we saw that example with stroke. If I take another example and I start with gout, you can see that the clinical content is tailored to every root term. We have this all throughout our vocabulary database, so that it makes it easy and clinically intuitive for providers to start with any root term that they want And with a few quick clicks, I can get down to the right level of specificity. And I should add that not only, providers don't have to do that, right? If they, if I'm documenting on this patient's gout as we see it, I can also go directly to that term. And I get taken directly to a term that captures that level of specificity, and I can easily add that term directly. So all of our conditions allow providers to find what they want if they want to start generally, or they can search through simple and easy to understand shorthand to get to exactly the right level of specificity without the click. Finally, I'd like to highlight another important example. Take a look at that diabetes on the left. As you can see, clinically, if I want to document that patient's diabetes today and address it, I might think, I see it on the longitudinal problem list, I'm going to add it to today's encounter. When I go to do that, notice what happens. I'm prompted that while clinically that diabetes sounds reasonable to me, I need additional specificity for a billable ICD code. Oh, excuse me, I got a little trigger happy with my screen. So with a few simple clicks, I can go from diabetes, and notice how when I choose kidney complications, as many of you may know, there's a myriad of end organ disease that comes with complications from diabetes. If I choose renal disease, all my subsequent choices are now tailored to the previous choice that I made, an easy to use workflow. And now I've gone through a few quick clicks. I've gone from what I thought was clinically appropriate, simply type 2 diabetes, to the right level of specificity, diabetes with chronic renal disease, on dialysis, and insulin use. And now, folks, when I add this term to today's encounter, I get not only that diabetes and the appropriate E11 code in that case, but I get the appropriate lifestyle and Z codes that come with that, as well as the code for end-stage renal disease. We have essentially eliminated the ability to unintentionally put an unspecified code on the problem, on a visit diagnosis encounter list. And in addition, put all the conditions related to the right level of billing in one place. So I hope I've been able to impress upon you some of those introductory comments that David mentioned in the talk around documenting with confidence and ease, problem list management tools, and how to highlight HCCs and focus on where the value exists. On that note, I'd like to turn it back over to my colleague who can wrap up comments, and we can open up to Q&A. David?
Yeah, thanks, Deepak. So we hope you saw a few ways that IMO Core can help you improve the workflows around problem list management, diagnosis capture using the cSmart app. So now that you've seen that, let's talk briefly about what that means to your organization. So in reducing the clinician HIT burden, i.e. improving your provider's EHR experience, our categorized problem list that demonstrated a 300% increase in adoption during a pre-go live pilot, where we granted access to 50 providers. And in 3 months, we saw that number of providers using active users of our categorized view of the problem list grow to 150 providers. And that was just through word of mouth alone. One doc telling another doc, hey, check out this new view of the problem list. So after seeing that growth and adoption, the organization decided to make it the default view across their entire organization. And once they did that, 99.8% of providers kept the categorized view over their standard alphabetized view of the problem list. And that led to better clinical data. After go live, that same organization saw a 163% increase in problem list cleanup activities because similar problems were grouped up together and providers took it upon themselves to organically clean up those unnecessary problems. We also saw a corresponding decrease in new duplicative problems being added, again, because the provider was able to review the full problem list, get an understanding of that patient, and see the problems that were already there so that they didn't have to introduce a new instance of that problem. And of course, we can help you get paid appropriately for the care that you're already providing. IMO's ICD-10 coding tools have demonstrated a 10% decrease in denied claims and 24% increase in Medicare Advantage risk scores. So we hope you saw a few ways IMO Core can help you improve your workflows. But IMO can provide additional terminology solutions to optimize your surgery scheduling system or your procedure terminology more generally. We also offer IMO Precision Normalize, which can standardize and clean up your organization's data across all domains. And with this clean, standardized data, IMO's precision sets can help form the foundation of your analytics, offering clinically validated value sets based on IMO's best-in-class terminology. If you'd like any additional information on any of those solutions, or would like to schedule a more in-depth discussion of our cSmart app with others in your organization, please go to imohealth.com to schedule a demo. So we thank you for joining us this afternoon, and we'd invite you to stick around for a brief Q&A session with our panelists.
Great, thank you, David. We've got a few questions that came in, so I'll start with what version of Millennium is cSmart compatible with? David, could you answer that?
Yeah, sure could. It is compatible with Millennium code level 2015-01 or above.
Okay.
We are, I saw another question come in about ASP. We are exploring other Cerner platforms, but we are focused right now initially on PowerChart. And once we have some learnings there and have worked with Cerner to integrate into those other platforms, we hope to expand to Cerner's other offerings as well.
Great, thank you. The next question that came in is, how can I set diagnosis priority using your app?
Yeah, great question. There is not a way, FHIR does not support diagnosis priority through their APIs, but worked with Cerner to allow, to create a feature within Cerner that when a diagnosis is added through our app, Cerner will automatically assign a diagnosis priority to that new diagnosis. And it'll be added in the order that those diagnoses are entered. If you'd like to then go back and adjust your priority, adjust the ranking, you can through Cerner's problem list or through downstream workflows as you're creating your visit document. There's a way to do so there as well. So again, because of a limitation of the FHIR API, we cannot set the diagnosis priority within our app, but we have worked with Cerner to make sure that the diagnosis priority is being assigned to new diagnoses being added through our app.
Excellent, thank you, David. Another question that came in, so how does this work with my existing problem lists in Cerner today?
Sure, Deepak, do you want to take that one?
Hi, yeah, absolutely. Thank you folks for that question. And it's a great question. In fact, what I was able to show you was ways in which users would interact with problems and diagnoses. This is in fact not a separate problem or diagnosis database. It is in fact reading and writing to the very same problems and diagnosis tables that exist in your Millennium instance today. And so any changes that you make through our app will be reflected in the native tables and all the places where that would appear normally, be it the diagnosis and problems tab on the left navigation menu, in the native problem list that exists within M Pages or anywhere else, as well as all the downstream functions that are supported by those problem diagnosis tables. So it's just a different way for providers to interact with the existing database.
Great, thanks, Deepak. So one more question, similar along the same lines. So Cerner does have their own version of an HCC solution. Will this work? Will IMO Core cSmart work alongside that?
Yes, absolutely. Essentially, what we are able to do is for the data that exists within the Millennium instance, we are essentially organizing it and presenting it in a unique view that allows providers to focus on those that haven't been addressed that year. And any changes that one makes through our app, and similar to the response I gave earlier, are then reflected in the normal ordinary database that already exists in Millennium. So all of the other features, be it healthy intent, be it other features within Millennium that call out HCCs, all that still works as is.
Excellent, thank you. Right, it looks like those are all of the questions that came in, so I'll do one last call for questions. David, Deepak, is there anything else that you'd like to add before we wrap up?
Thanks, Nicole, for that opportunity. I would just, from a provider perspective, I do think that making problem lists simple and easy to use, making them and reducing the amount of complexity that occurs when you don't have the right level of specificity on the diagnosis side. These are all ways in which we can, A, get providers to engage with problem lists more, and B, do it in a way that's consistent with their workflow. And I think that ends up improving adoption in a variety of ways.
Yeah, I double down on that. I think that I'm a little concerned that, some people are kind of writing the problem list off, and that's really a problem because it is so central to so many clinical workflows. It drives reimbursement, because the problem list is what providers are often documenting off of. So we need to fix the problem list. And we think it's an issue of tooling, that because the problem list is in EHRs is under-tooled today, it's cumbersome. And providers don't have the time to fight with a feature in the EHR that is, a real pain point to them. So if we can make the problem list easier to use, if we can lower the bar to engagement, then we think providers will come back and start using it as a useful clinical tool in their workflows. And I think we've demonstrated that with the story that we shared earlier about adoption and changes in provider behaviors once they had a categorized view. I think we have seen that and are looking forward to bringing that story to Cerner and helping our Cerner clients see some of the same successes that we've seen in other EHRs.
And also to add to that, the benefits on the diagnosis side around specificity and secondary codes and being able to extract maximum documentation when it comes to the billing side of things on encounters. Doing all of that, what David mentioned, as well as on the billing side, as well as on the visit diagnosis side, in an easy to use way is critically important for that adoption.
Excellent. Well, thank you both, and thank you to everyone who attended today. We are very excited to collaborate with Cerner to help improve code capture at the point of care and make problem lists more meaningful. We'd be more than happy to talk to you more, get a deeper dive. So if you're interested in a demo, please visit imohealth.com to schedule a demo with us, and one of our team members would be happy to reach out to you. So with that, hope you have a great rest of your day. Thank you, David and Deepak, for the presentation.
Thank you all. Have a good afternoon.
Thank you.